Everyone. Today we are going to study about the oral anticoagulants. So continuing with the discussion on antiplatelets, anticoagulants and fibrinolytic drugs. I have already discussed about the antiplatelet drugs. Then we have discussed about the parental anticoagulant drugs, and today I am going to discuss about the oral anticoagulants. Okay, so if you have not seen those videos, first of all you have to start with those videos and then you come to this oral anticoagulants. Now the prototype drug in the oral anticoagulant group is warfarin. So oral anticoagulant, the prototype drug is warfarin, our age-old friend. However, in the recent years, we have also developed direct oral anticoagulants. In this lecture, I'll be discussing about warfarin, and in the next lecture, I'll be discussing about the direct oral anticoagulants. Now let us start with warfarin. Warfarin is a vitamin K inhibitor. So basically, warfarin has two components. It is a racemic mixture of R isoform and S isoform. As you can see here, R isoform and S isoform. Now, for all practical purposes, this S isoform or S isomer is most important clinically. Okay, and this is responsible for majority of the inhibition of the vitamin K cycle. Before going into that, we'll just understand what is vitamin K cycle. So the vitamin K is needed for gamma carboxylation of some of the clotting factors. Okay, so those clotting factors include factor 2, factor 7, factor 9, and factor 10. So these are the clotting factors, and these clotting factors need vitamin K to become activated. Okay, so for activation of these clotting factors, vitamin K is required, and it will cause gamma carboxylation of the glutamyl residue that is present in these factors. Okay, so after gamma carboxylation of the glutamyl residues of these factors, they will be activated. Apart from these factors, vitamin K also activates protein C and S. Protein C and S. Factor 2, 7, 19, they help in clotting. Protein C and S, the function of protein C and S is to inhibit the clotting. However, the majority of the function of vitamin K inhibitors or warfarin is because of the inhibition of the activation of factor 2, 7, 9 and 10. That's why warfarin is used as anticoagulants. Okay. Now this vitamin K, the reduced form of vitamin K is required for this activation of clotting factors. Okay, so reduced form is required. Now in the process of activating these factors, this vitamin K has to be oxidized. So vitamin K will be oxidized to oxidized vitamin K in the process of activating these enzymes, and the enzyme that is responsible for this process is gamma glutamyl carboxylase. Okay, so gamma glutamyl carboxylase will cause activation of the inactivated clotting factors with the help of reduced vitamin K. And in this process, the reduced vitamin K will be converted to oxidized vitamin K. Then oxidized vitamin K has to be converted back to reduced vitamin K, and this process happens because of vitamin K reductase, this enzyme. Now, what is the function of warfarin? So warfarin will inhibit this vitamin K reductase. Okay, so warfarin will inhibit this enzyme, and that is the mechanism of action of warfarin. And I told the S isomer of warfarin is the most important form that will cause inhibition of the vitamin K reductase. Then the next thing is this S isoform is metabolized by CYP2C9. Okay, this is metabolized by CYP2C9. R isoform, which is not very important, this is metabolized by CYP1A2, CYP1A1, CYP1A2, and CYP3A4. Okay. Now, some of the basic pharmacology that we need to understand is, first of all, I told warfarin, it is taken orally, so it's an oral anticoagulant. After taking orally, almost it is completely absorbed from the gut, from the GIT. It is completely absorbed. Peak blood levels are found at around 90 minutes after ingestion. The half-life is around 36 to 42 hours. And remember, majority of the circulating warfarin, that is around 97% or more than 97%, they are bound to albumin. Albumin is a plasma protein. So 97%, that means majority of the warfarin in the circulation, they are bound to albumin. That means less than 3%, they are only in the free form, and these are the active form of warfarin. These are the active form of warfarin. Okay, so more than 97% of warfarin, they are bound to albumin in the circulation, and only a minority, they are biologically active and they are present in the free form. Okay, I told that S isomer is metabolized by CYP2C9. That's why any polymorphism in CYP2C9 will affect the warfarin concentration in the blood. The important ones are, for CYP2C9, we have to remember that CYP2C9 star 2 and CYP2C9 star 3. These two polymorphisms are important. Because these polymorphisms, they have a reduced activity. That means the metabolism of S warfarin is delayed. Okay, if the patient has this polymorphism, this isoform of CYP2C9, the metabolism of S warfarin is reduced. That means the half-life of warfarin, the effect of warfarin is prolonged. So if the patient have heterozygosity, if they have heterozygosity for these polymorphisms, we need to reduce the warfarin dose by 20 to 30%. If they are homozygous, if the patient is homozygous for this polymorphism, then we may need to reduce the dose to up to 50 to 70%. 50 to 70% reduction of the dose is needed if the patient is homozygous for these two polymorphism. One more point is, this polymorphism is not very common in Asians. These are not common in Asians. It is usually seen in Caucasians. Similarly, some polymorphism of vitamin K reductase, the enzyme is named as VKORC. There is a polymorphism that is known as VKORC1 polymorphism. This polymorphism is common in Asians, and if this polymorphism is present, you may need to reduce the dose of warfarin to up to reduce the dose by 25%. Okay, so these are by 25%. This is by 25%. In case of CYP2C9-2 or CYP2C9-3, you have to reduce the dose by 20 to 30% if it is heterozygous, by 50 to 70% if it is homozygous. And if there is a polymorphism VKORC1, you may need to reduce the dose by 25%. Okay, so these are some of the basics of pharmacology of warfarin. Now we'll see how we can monitor warfarin. So warfarin is monitored by PT-INR. So the PT, we all know, it is actually a measure of the extrinsic pathway. Extrinsic pathway, you must be knowing that it starts from the factor 7, and then it will come to the common pathway, that is that includes the 10 and factor 2. So the PT values are affected by the extrinsic pathway and the common pathway activities. So because warfarin inhibits the vitamin K dependent factor, that is 2, 7, 9 and 10, so PT is prolonged in cases of warfarin therapy. Okay, so PT is measure of extrinsic pathway. And it is useful for warfarin monitoring. Okay, this prothrombin time is performed by adding thromboplastin. This reagent contains tissue factor, phospholipid and calcium. And then we'll check the time for clot formation, INR, it is derived from the PT value itself. It's a standardized value comparing with the international standards. And our target INR, if the patient is on warfarin, is most of the cases it is up to 2 to 3. So we'll start the patient on warfarin, then we'll check the INR. If the INR is below 2, if the INR is below 2, we will try to increase the dose of warfarin. If the INR is more than 3, then we'll try to reduce the dose of warfarin so that it can be maintained, the INR can be maintained between 2 to 3. However, if the patient has mechanical aortic or mitral valve, the target is slightly high, that is 2.5 to 3.5. One more point I forgot to tell you in the pharmacology, that the effect of warfarin comes after around 5 days. Because if you understand the mechanism, the function of warfarin is to inhibit the activation of vitamin K dependent factors. Okay, its function is to inhibit the activation of vitamin K dependent factors. So if the factors are already activated, warfarin doesn't have any effect on them. So that's why it will take some time. It will take around 5 days to produce its effect. So that's why I told you in the previous lecture also that if you want the anticoagulation effect, immediately we have to start with a parenteral anticoagulant, and along with that you have to start warfarin up to around 5 days till the INR comes to the therapeutic range of 2 to 3. We have to continue the parenteral anticoagulant, and then once the INR is in the therapeutic range, you can stop the parenteral anticoagulant and you can continue the oral anticoagulant. Coming to the side effect, for all anticoagulants, antiplatelet agents, the most common or the most important side effect is bleeding. Okay, so the bleeding. So how will you manage the bleeding? So remember, if the INR is more than 3.5 up to 10, and if the patient is asymptomatic, that means the patient doesn't have bleeding, but on routine INR monitoring, you found that the INR is more than 3.5 up to 10. In these cases, you can just withhold warfarin for some days. You can just withhold warfarin for few days, and you can repeat the INR, and accordingly you can modify the dose. If the INR is more than 10, you can give oral vitamin K. Of course, you have to stop warfarin and give oral vitamin K. If it is or anytime if there is bleeding, you have to give IV vitamin K, and also you have to give the factor replacement. The factor replacement can be given through FFP, that is fresh frozen plasma, or more selectively you can give prothrombin complex concentrate. That is the 4-factor concentrate. This 4-factor concentrate, it will have factor 2, 7, 9 and 10. All the vitamin K dependent factors will be there in 4-factor concentrate. So this is a more selective approach. However, in most of the centers this is not available. So the thing that is most commonly used is FFP. So if the INR is in the range of 3.5 to 10 and the patient is asymptomatic, just withhold warfarin for some days and repeat INR. If INR is more than 10 and patient doesn't have bleeding, you can just manage with vitamin K after stopping warfarin, oral vitamin K, and withhold warfarin. And anytime if the patient has bleeding, if bleeding is there, definitely you have to stop warfarin. You have to give IV vitamin K, and along with that you have to give factor replacement. Okay, you have to give factor replacement FFP or prothrombin complex concentrate or 4-factor concentrate. Okay. One thing I'll just mention here. Usually the starting dose of warfarin is 5 to 10 mg. 5 to 10 mg, and then we will check INR. Most of the times, around 5 to 6 days, it will come to the therapeutic range of 2 to 3, and then we can continue the same dose. Warfarin has a very narrow therapeutic index. That's why very frequent monitoring of INR is required. So once it is 2 to 3, we will continue with the same dose of warfarin, and after around 2 to 3 weeks, after around 2 weeks, we will repeat the INR. If it is subtherapeutic, if it is less than 2, you have to increase the dose of warfarin. If it is more than 3 or 3.5, you have to reduce the dose of warfarin. Ideally, the change in the warfarin dose should not exceed 20% of the current dose. For example, if the patient is on 5 mg and INR is less than 2, you have to increase the dose to 6 mg. 6 mg means there is increase by 1 mg, that is 20% of 5 mg. 20% of 5 mg is 1 mg. So we will give 6 mg. So ideally, you should not increase more than 20%. Okay. However, in some situation where the warfarin, the INR is significantly subtherapeutic, you can increase the dose to somewhat higher level, but ideally it should be 20% of the current dose. Okay, and because they have a very narrow therapeutic index, frequent INR monitoring is required. So initially we will do the INR monitoring in every 2 weeks or 3 weeks, and once the INR is stabilized, then you can increase the frequency, or you can reduce the frequency of doing the monitoring. Okay. Now the second side effect is skin necrosis. I have told during the when I discussed about the heparin-induced thrombocytopenia that warfarin has a risk of skin necrosis. This is usually seen after 2 to 5 days of initiation of warfarin therapy. These are actually well demarcated erythematous lesions. Of course, there will be necrosis, and this necrosis is predominant in the center. Usually, the fatty areas are affected: buttocks, thigh, wrist. The fatty areas are affected most commonly. Toes are also affected. And if you take biopsy of this lesion, from the periphery, that means near the normal skin region, biopsy from periphery, if you take, you may get thrombus, thrombi in microvasculature. This warfarin-induced skin necrosis is most commonly seen in patients with protein C bar S deficiency, either congenital or acquired. So if the patient has already protein C and S deficiency, and if you give warfarin, I told warfarin also inhibits the activation of protein C and S, and I told protein C and S, they help in preventing clot formation inside the blood vessels. Okay, so if the patient already has a protein C and S deficiency, those patients, if you give warfarin, some of them might develop skin necrosis because the anticoagulant effect of protein C and S is completely lost. Okay. So what to do in these cases? Of course, you have to stop warfarin, withhold warfarin, give LMWH or unfractionated heparin for anticoagulation purpose, and also you have to give FFP bar prothrombin complex concentrate. The next side effect is pregnancy. In pregnancy, if in the first trimester you are giving warfarin, then there is a risk of fetal warfarin syndrome. Fetal warfarin syndrome. Now, what is fetal warfarin syndrome? Sometimes they give this name, Shala syndrome. So this includes nasal hypoplasia, and stippled epiphysis. Stippled epiphysis. Stippled epiphysis means in the epiphyseal lesion there will be stippling like this. I forgotten to put the images here. You can just search it in Google and see how stippled epiphysis looks. I told higher risk is there in first trimester. As you increase the trimester, the risk of fetal warfarin syndrome reduces. That's why in pregnancy, we tend to withhold warfarin. So those patients who are on anticoagulant warfarin for longer time, you have to stop warfarin during pregnancy, and instead of warfarin, you can give unfractionated heparin or low molecular weight heparin. Okay, you can give unfractionated heparin or low molecular weight heparin, and after the pregnancy, you can start with warfarin because warfarin is not released in breast milk. Is not released in breast milk. So after pregnancy, after delivery, you can start on warfarin, and this is safe because it is not released in breast milk. Breast milk, this is safe during lactation. So it is contraindicated in pregnancy, but it is safe in lactation. Now coming to, okay, so the picture is here actually. Now coming to some of the special problems, one such scenario is patients with lupus anticoagulant. Now what is the issue with lupus anticoagulant? If the patient has thrombosis, patients with lupus anticoagulant, patients with Apla syndrome, antiphospholipid antibody syndrome. Now in these patients, if the patient has thrombus already and you have started on warfarin, even though patients with lupus anticoagulant, they are at higher risk of thrombosis, the target INR is still 2 to 3. Studies have shown that even if targeting a higher INR in this kind of patients who are at higher risk of thrombosis is not as effective as keeping the INR 2 to 3. So the recommendation is even in patients with lupus anticoagulant, if they have thrombus and you have given warfarin as anticoagulant, INR has to be kept between 2 to 3. Okay. The other issue is lupus anticoagulant itself. It can increase the INR. It can increase the INR. So in these patients, if you are using warfarin, it is better to monitor with factor 10 levels. So monitor these patients with factor 10 levels instead of INR because lupus anticoagulant also increase the INR. Then if the patient is planned for surgery, patient is on warfarin and the patient is planned for surgery, then what to do? If it is a low risk procedure, low risk means something like dental cleaning or simple dental extraction, cataract surgery, or skin biopsy. In these cases, in low risk cases, you need not withhold warfarin. But if the patient has moderate to high risk of bleeding, if the patient has moderate to high risk of bleeding, then you have to stop warfarin for 5 days before the surgery. And once the INR comes to the normal range, then you can proceed for surgery. But sometimes it is very difficult to stop the warfarin because of the higher thrombotic risk. So for example, patients with mechanical heart valve, in these patients, if you stop warfarin, there is a very high risk of thrombus formation. So in these kind of patients, if they are planned for surgery, then you have to withhold warfarin, of course. Then you have to start with low molecular weight heparin or unfractionated heparin. once INR is less than 2. Once INR is less than 2. So you will stop warfarin. You will see the INR. Once it is less than 2, start the patients on low molecular weight heparin or on fractionated heparin. This has to be stopped 12 to 24 hours prior to surgery. 12 to 24 hours prior to surgery. And once surgery is over, then again you can start the patients on warfarin. Again you can start with warfarin. Okay, so it's very simple. If it's a low risk procedure like simple dental cleaning, simple dental extraction, cataract surgery, skin biopsy, you need not withhold warfarin. If it is a moderate to high risk, definitely we have to withhold warfarin 5 days prior to the procedure, and once the INR is normal, then only you can proceed for surgery. If it is a moderate to high risk procedure, but also there is a high risk of thrombosis, like in cases of patients with mechanical heart valve. In those cases, we have to withhold warfarin, and once the INR is subtherapeutic, that is less than 2, you start with parental anticoagulants, low molecular weight heparin or unfractionated heparin. Continue them till the surgery, but we have to stop this heparin also 12 to 24 hours prior to surgery. And once surgery is done, after that, once hemostasis is achieved, we can again start with warfarin. So that's all about warfarin. In the next lecture, I'll be telling you about the direct oral anticoagulants.